Session 5 goes deeper on how primary care doctors actually get paid. We review RVUs and upcoding games in fee for service primary care. We also delve into different payments and value based care across entities like HMOs, Medicare Advantage, self funded employers, and direct primary care.
There's really only two ways to pay for healthcare services. One at the time of the service, or two to prepay. Paying at the time of service traditionally is known as fee for service, and paying ahead of time is generally known as capitation. Nowadays, capitation is called value-based care, and using the same acronyms, we can call fee for service volume-based care. To start, let's talk about fee for service. The foundation of fee for service payment is the RVU, or the relative value unit. In a nutshell, RVUs are assigned to each CPT code and determine how much a procedure or a office visit is worth. So one procedure may be worth 5 RVUs, an office visit may be worth 1.5 RVUs. And if you remember earlier when we talked about physician compensation, a lot of compensation is based in the fee for service world on how many RVUs you can generate in any given year. The value of an RVU is generally determined by CMS. How many RVUs each procedure is assigned is decided by the RUC, also known as the RVS Updating Committee. This is a committee put together by the American Medical Association that's comprised of all the medical specialties, all doctors, who sit in a circle, shake hands, pat each other on the back, and basically make deals regarding how many RVUs each procedure or visit is worth. This is a highly political process and generally a zero-sum game. If one procedure takes some RVUs, another procedure has to lose some. So in fee-for-service, volume-based care means the more patients, the more RVUs you generate, the more money you make. There's something called upcoding, which is fairly widespread amongst practices. And essentially, it's trying to find every which way to make a visit seem more complex than it is. For example, 99213 is considered a simple visit, and a 214 is considered a slightly complicated visit in order to justify each one. But in 2021, the E&M guidelines changed so that it's much easier to justify higher codes and significantly actually reduces the burden. So previously we had to click a certain number of physical exam findings, certain number of review of systems. A lot of these were templated and more people didn't actually do them than actually did them. And it was more documentation than clinical care. So upcoding is one way to generate more RVUs, widespread, something that shouldn't be done, but it's done a lot. Under volume-based care, the misaligned incentives present pretty early and readily, which is why you see a move away from, or an attempted move away from fee-for-service models. So a 99213 ballpark is worth around $90. A 99214 is $120. So if we were to see a 99213 make a referral out to a specialist versus a 99214 and take some extra time to educate the patient, treat the patient, handle the issue, it would make sense in a perfect world to do the latter and actually take care of the patient. But if you could do two 99213s in the time that you did a 99214, what would you do? Probably the two 99213s, in which case you would be making $180 over $120. What's more interesting is value-based care because prepaid medicine has so many different flavors. The whole basis for value-based care is to meet the triple aim. The triple aim is to try and improve patient experience, decrease costs, improve level of care, And then sometime along the way, they decided doctors were people too. And so they turned it into the quadruple aim and said improve the provider well being. The biggest way that value based care can be split is risk versus no risk. So when we look at when HMOs first started under the Nixon administration, Nixon was a big fan of HMOs because it was a way that insurance companies could decrease utilization while decreasing cost. And one of the reasons these plans were hugely unpopular in the early 90s was because there was no risk involved. So essentially, what would happen is the insurance companies would assign patients to doctors' offices, and the doctors realize, oh, I can make a certain number of money per patient, regardless of the level of care. And so the worst of the worst would accept these HMO patients, pretty much shut down their office, only open 2 days a week, and by doing nothing, rake in huge profits. Nowadays, most of the value based care arrangements have some sort of risk involved. The most obvious and widespread right now is Medicare Advantage, where the provider or practice participating with the Medicare Advantage plan gets the global capitation, and anything at the end of the year, any savings at the end of the year, they get to keep, and any losses incurred, they lose. In this regard, sure, it's a capitated payment, but now they actually have a responsibility to do something for the patient that actually decreases global costs rather than just shutting down their doors and doing nothing and not worrying if that patient went to the ER for actual care. And in fee for service, we were talking about upcoding. Medicare Advantage companies and plans have come under fire recently as well for their own version of upcoding, which is code farming. So instead of saying this visit is worth $120 when it really should be worth $90, they are paid by how sick the patients are. The patients get HCC codes, which is short for hierarchical condition category codes. And the more codes a patient has, the bigger the pool of money they get. So in this game, if you code a patient to be as sick as possible on paper, you generate more money. And so in fee for service, you make your visits look worse. In a code based capitated plan like Medicare, you make your patients look as sick as possible on paper. On the employer side, the self funded plans have always been inherently a risk model because any money they save at the end of the year is their money to keep. Any money they lose is incurred. And if they hit their stop loss insurance, then their stop loss premium goes up the following year. When a patient pays under a value based care system, it's known as direct primary care, where the patient pays a per member per month. And this one's a little different because there's no risk involved. So whether or not the doctor actually helps them out long term, it's irrelevant to end of the year. There's no extra bonus, no money lost. The real main focus in this model is the doctor just has to make sure the patient is happy with their services because the patient is a direct customer. And if the DPC is constantly closed and the patient has to go to the urgent care, the ER, or if the doctor clearly doesn't know what they're doing, patient keeps getting sicker, then the patient just takes their money and leave. So this game is not so much a risk game as much as it is a customer service game.
To summarize, we learned about payment details in fee for service and value based care arrangements at a high level. You now know what RVUs are, the shenanigans of the ruck, and how prepayments work in capitation models across private insurance, Medicare, employers, and direct primary care. This concludes session 5.